The skull exists in our imagination as this sort of static, maybe a bit grim, bleached anatomical model.
Right, the plastic one from a science classroom.
Exactly. But that image does a fundamental disservice to what is a living, growing, highly articulated piece of biological architecture.
Indeed. It's an engineering marvel, not just a simple helmet. It is a structure designed to protect the most critical organ we possess, the brain, but it simultaneously houses the incredibly delicate machinery of our special senses.
You mean the origins of sight, smell?
The precise origins of sight, yes, the fine channels for smell, and the complex structures governing hearing and balance. Beyond all that, it's the mechanical backbone. It provides the leverage and support for the movement of the entire head, and, fundamentally, the mobility required by the mandible for chewing and speaking.
Our mission today is to dive deep into a formidable stack of intensely detailed anatomical sources focusing solely on this bony architecture. We're going to examine it from the microscopic level, look at how the bones are built, all the way up to its macroscopic developmental growth patterns.
Sounds ambitious.
It is. But our job is to extract the most important nuggets to give you, the listener, a thorough, almost microscopic understanding of this foundational structure. We want you to finish this deep dive with an appreciation of the skull as a three-dimensional, interconnected puzzle where every single ridge and every tiny hole has a vital purpose.
To navigate this complexity, we absolutely must establish the major organizational structure right away. When we talk about the adult skeleton, which comprises about 28 separate bones, depending on if you include the ear ossicles and the hyoid bone.
Which are sometimes counted separately, right?
Exactly. It divides into two major functional and developmental components. First, you have the neurocranium.
The neurocranium being the brain protector.
Precisely. It is the protective shell. It, in turn, is subdivided into the calvaria, which is the dome, or the skull cap, the roof, and the cranial base, which is the floor upon which the brain rests.
And the second major component is what gives us our distinct human appearance.
The viscerocranium.
The viscerocranium, or the facial skeleton. This includes the major facial plates, the zygomatic bones, the maxillae, so the upper jaw, and of course the single movable bone of the entire structure, the mandible.
And here is the first point of complexity that often trips people up. To truly grasp the skull's architecture, you can't just separate the neurocranium and viscerocranium cleanly. The cranial base, that complex floor, is actually formed by contributions from both sides.
Great. So parts of the facial skeleton are actually part of the floor for the brain.
That's it exactly. They integrate right into the floor, protecting the brain. This mixing of components makes it an incredible architectural feat. That's why we have to view it from all four major perspectives. Anteriorly, so the face, laterally from the sides, inferiorly, the base from below, and crucially, interiorly, looking down into the fossa.
That sets the stage perfectly. Let's start with part one, the foundations of the skull. Before we name all the individual pieces, let's talk about how these pieces are built and where they originate, because that dictates their strength and their clinical vulnerabilities.
Let's do it.
Let's focus on composition. We've established the adult structure is composed of around 28 separate bones. But structurally, what are we looking at when we talk about, say, the side of the skull cap? Our sources describe a specific sandwich model.
That analogy is perfect. The general structure, especially in the calvaria, is designed for maximum protection against impact. You have a core layer of thick, spongy, cancellous bone anatomus. Call this the diplo.
Diplo. D-I-P-L-O-A.
Correct. This diplo layer is, in turn, entirely encased and supported by two layers of much denser, compact bone, an outer table and an inner table. This structure is fantastic for shock absorption.
So if you sustain a blunt force trauma, the outer table might fracture, but that spongy diploid core acts like a shock absorber, hopefully dissipating the energy before it reaches the inner table and the delicate structures beneath.
Exactly. The layered design spreads the force out. However, and this is a big however, the composition isn't uniform everywhere, and this is where clinical relevance comes in. The source material highlights that while the calvaria, the dome, is generally thick, the facial bones and specific parts of the cranial base can be surprisingly thin.
Almost paper thin in some spots.
Paper thin. And this variability in thickness, well, it's important beyond just resisting a blow.
Why is that? What are the other implications?
It creates specific challenges in surgery. This thickness variability makes bone grafting material selection challenging but critical. If a surgeon needs to harvest bone, say, from the calvaria to repair a defect elsewhere, they need to know precisely where the bone is thickest and where the diploe is present. A thin section won't provide the robust structural support needed. It just underscores that even at the millimeter level, this architecture matters.
Now, here is where it gets really interesting for me. the developmental origins.
Yeah.
You mentioned that the various bones of the skull don't all follow the same construction blueprint. They form through two fundamentally different processes.
That's the key to understanding the adult structure. Most of the skeletal components form through either endochondral ossification or intramembranous ossification. These two processes dictate the final shape, the structural integrity, and how the bone reacts to stress and growth hormones.
Okay, let's unpack this. Start with endochondral ossification.
Endochondral ossification, quite simply, means within cartilage. The bone starts as a temporary cartilaginous template, a flexible model that is gradually and systematically replaced by hard bone tissue. This process, which is how most long bones in the body are formed, is reserved for the deep foundational parts of the skull.
So the really complex bits.
The really complex bits. This includes the majority of the cranial base, specifically the anterior and posterior sections.
So the foundation and the complex articulating joints of the skull base, which interact heavily with the spine and the pharynx, are built from cartilage first. Why is that specific blueprint necessary for the base?
Because it allows for complex, multi-directional growth and articulation. The base needs to fit together like an intricate lock, and that cartilage template allows for that intricate shaping during fetal development and rapid growth in early childhood. Now, contrast that with the method used for the roof and walls.
That would be intramembranous ossification.
Correct. The majority of the calvaria, the dome that covers the brain, along with some parts of the middle cranial base, develops directly via intramembranous ossification. The bone forms directly from a membrane of connective tissue without ever needing a cartilage model.
So the dome is built like sheet metal, directly on a template, while the base is sculpted from a preformed wax model.
That's a great way to think about it. And that distinction explains why the cranial vault can expand so rapidly and evenly to accommodate brain growth, while the base maintains its intricate, rigid joint system.
And this dual origin also has clinical repercussions later in life, right? You mentioned healing.
Precisely. Intramembranous bone often heals and remodels differently than endochondral bone. It's something surgeons have to consider.
We absolutely must dive back into that middle cancellous layer, the diploe, because you alluded to a dangerous connection there.
The connection is vital and potentially very hazardous. The diploe contains not only bone marrow, but also a network of slow-moving blood vessels known as the diploic veins.
Okay.
What's fascinating and clinically frightening is that these diploic veins do not drain exclusively locally. They drain directly into the large, low-pressure venous structures inside the skull, the intracranial venous sinuses.
And if you have a direct connection from the highly exposed outer skull layers to the brain's venous drainage system, that's essentially a fast lane for bad actors.
That's the perfect analogy. A hazardous circulatory link. It provides a direct pathway for the spread of infection, for example, a severe untreated cellulitis or abscess on the scalp or the face or in the orbit. If it manages to infect the diploe, it can provide a direct route for pathogens to travel right into the cranium.
Which could lead to what exactly?
Potentially serious, life-threatening intracranial complications. We're talking about meningitis, osteomyelitis of the skull, or venous sinus thrombosis. This seemingly innocent spongy layer is a crucial weakness in the protective armor.
So even the protective architecture has an inherent trade-off.
Yeah.
Incredible. Now, let's talk about the joints connecting these sheet metal plates of the calvaria, the sutures. How do they maintain rigidity while accommodating the stresses of daily life?
Well, sutures are not simple cracks. They are highly specialized fibrous joints. They come in two primary types. You have the simple sutures, which are relatively straight connections, but the majority, especially those under significant mechanical stress, are the complex interdigitated serrated sutures. Think of them like two pieces of a jigsaw puzzle fitted tightly together.
Why the serrated pattern? Why not just a strong, straight joint?
The serrated butt-end configuration is mechanically vital. It dramatically increases the surface area of contact, which in turn offers high resistance to tensile forces and traction. When you take a blow or subject the skull to rotational forces, that intricate interdigitation prevents the bones from sliding apart or being pulled away from each other.
I remember the sources mentioning an intriguing defensive role for those serrated joints.
Yes, this is a fascinating engineering concept. These sutures also act as natural, predictable fracture lines, a defer in defense mechanism.
A defer and defense mechanism, what does that mean?
It means if the force applied is overwhelming, the suture lines are designed to resist, but should they fail, they often fracture along these predictable, highly stressed lines. This controlled failure sacrifices the joint line to dissipate energy and potentially preserve the overall structural integrity of the main bone plates and the vital organs beneath them.
That's a sophisticated defense mechanism, a controlled breaking point to save the whole structure. Now, comparing that to the base, the cranial base doesn't have these sutures in early life, does it?
No, it has the different joints born from the endochondral process. The temporary primary cartilaginous joints, or synchondroses.
Synchondrosis.
These are essentially temporary growth plates, crucial for the massive expansion required for the cranial base to grow forward and laterally.
And their fusion timing is a biological clock, right?
Absolutely. The closure of these synchondroses is a key developmental marker. The most important and the gold standard in forensic or clinical contexts for adolescent age determination is the spheno-occipital synchondrosis.
Where exactly is this crucial joint located?
It lies right between the body of the sphenoid bone and the basilar part of the occipital bone, a foundational joint at the very center of the cranial base. It is a temporary growth plate that typically fuses completely between 13 and 18 years of age.
13 to 18, that's a pretty specific window.
It is. Once it fuses, the growth plate is gone, and the length of the posterior cranial base is cemented. Because this process is hormonally regulated and highly predictable across populations, its closure provides one of the most reliable bony indicators of age during that crucial period of adolescence.
That's a perfect hinge point between developmental growth and the final adult structure. With the foundational building blocks established, let's move to part 2 and look at the whole package, the exterior architecture that defines our faces and the shape of our head.
Let's do it.
Viewing the skull anteriorly from the front, we see immediately that the overall shape is an ovoid, characteristically wider above than it is below. It is visually dominated by 3 major features: the orbits, the central nasal aperture, and the maxillae housing the teeth.
The face is a complex and often delicate mosaic of individual bones, but the bony sockets for the eyes, the orbits, are our structural starting point, defining the upper third. The orbital rim itself is formed by interlocking contributions from several different bones.
Give us the breakdown of that rim.
Okay, so the superior border, the suborbital margin, is formed entirely by the frontal bone. As you trace that rim downwards, the lower border is formed by the maxilla, the upper jaw, and moving laterally, the prominent zygomatic bone. The integrity of this bony rim is paramount as it protects the delicate eyeball.
And you mentioned that the shape of the orbit itself varies widely. Why is that anatomically relevant?
While the shape of the orbit, whether it's more rounded, more square, or the angle of its lateral wall, varies significantly among individuals and populations. Our sources note that this wide variation is directly useful in forensic contexts for the prediction of facial features, as the orbital shape dictates the placement and projection of soft tissues around the eyes.
Let's detail the major bone contributions that form the central face. The maxilla is the powerhouse here.
It is the central piece of the puzzle. The maxilla forms the majority of the midface. It houses the upper teeth within its alveolar process. It contributes substantially to the floor of the orbit, and it forms the anterior 2/3 of the hard palate. Its size and projection are fundamental to facial structure.
Then we have the distinctive protruding zygomatic bone, the cheekbone.
The zygomatic bone is crucial for facial prominence, but structurally it doesn't stand alone. We must emphasize the completed structural unit, the zygomatic arch. This is a strong, curved bridge formed by the meeting of 2 separate major processes.
That's a great piece of anatomical teamwork. It's the meeting of the zygomatic process of the temporal bone and the temporal process of the zygomatic bone.
They lock together.
They lock together, creating that prominence which is easily felt on the side of the face.
And that arch is not just cosmetic. It provides critical protection for the temporalis muscle as it descends to attach to the mandible, and it also dictates the width of the face.
Looking medially, we find the 2 small, paired nasal bones right at the top of the nose. These are extremely fragile.
They are, and their dimension and angle determine the overall shape and height of the bony bridge of the nose. Deeper inside the nasal cavity, providing the central separation, we find the delicate ethmoid bone and the thin, plowshare-shaped vomer, which together form the majority of the nasal septum.
If we look closely at the center of the face, where the nasal aperture is, that bony opening is highly informative.
That is the piriform aperture, the bony opening for the nose. We look for 2 specific landmarks at its lower margin. The first is the anterior nasal spine, a small, sharp projection at the base. The second is the shape and inclination of the lower margin itself.
And why is that important?
What's fascinating here is that the morphology of this aperture and its inferior margin vary significantly between different ancestral populations, which leads to distinct facial and nasal profiles.
So those subtleties become key indicators in forensic analysis.
Absolutely. And as we move to the lower third of the face, we introduce the mandible. The mandible is a crucial element that distinguishes the face as dynamic. As the only movable bone of the skull, it articulates with the temporal bone at the temporomandibular joint, or TMJ.
How does all this detailed exterior anatomy translate to the real world for the learner? Why should you care about this?
The source material repeatedly hammers this point. Understanding these specific bony margins and the thickness and shape of the underlying bone contributions is foundational for forensic facial reconstruction. The bone provides the scaffolding.
I see.
Standard soft tissue depth measurements are taken relative to landmarks like the zygomatic arch and the orbital rim. If the underlying bone structure is misinterpreted, if you confuse a male's robust mastoid process with a female's, for example, the entire facial approximation will be skewed. It's the geometric prerequisite for the final outcome.
All right, let's shift our perspective to the top, the sides, and the back. Starting with the superior view, focusing on the calvaria or skull cap. While the overall shape varies dramatically, the sutures are the roadmap here.
They define the borders of the great frontal and parietal plates. Superiorly, we identify three major sutures. The coronal suture, running roughly ear to ear, separating the frontal bone from the two parietal bones. The sagittal suture, running longitudinally along the midline between the two parietal bones, and posteriorly, the lambdoid suture, separating the parietal bones from the occipital bone.
And the meeting points have their own names, right?
They do. The junction where the coronal and sagittal sutures meet anteriorly is known as the bregma. Posteriorly, the junction of the sagittal and lambdoid sutures is the lambda. These serve as key reference points for cranial measurements, so craniometry and developmental assessments, particularly in early life.
Now, moving to the side, the lateral view, we encounter the expansive shallow depression known as the temporal fossa. This area isn't empty. It's the large housing for the temporalis muscle, which is responsible for closing the jaw.
The boundaries of the temporal fossa are critical. Superiorly, the extent is clearly limited by the inferior and superior temporal lines, which are curved ridges ursing across the parietal and frontal bones. Inferiorly, the fossa is sharply defined by the strong, easily palpable zygomatic arch.
And where the frontal, parietal, sphenoid, and temporal bones come together, we find one of the most clinically critical spots on the entire body, known as the Piturion.
The Piturion, it's often described as an H-shaped junction, and it's located approximately 4 centimeters above the midpoint of the zygomatic arch. It is a major area of anatomical vulnerability because, structurally, the bones are thinned and overlap here. But the clinical significance is not the weakness of the bone itself, but what lies directly beneath it.
Tell us why a blow to the Piturion is so dangerous.
Deep to this thin, vulnerable point runs the anterior branch of the middle meningeal artery. This artery supplies the dura mater, the tough outermost membrane covering the brain. A sharp, localized blow to the Piturion can easily fracture the underlying temporal or sphenoid bone, lacerating this artery. Since the artery lies outside the dura, a rupture leads to a rapid accumulation of blood in the epidural space, causing a devastating epidural hematoma. This pressure builds quickly, demanding immediate surgical intervention.
It is the perfect illustration of anatomy, immediately translating into life or death risk. Now, let's complete our external survey with the posterior view, which is dominated by the powerful occipital bone.
The occipital bone is where the power of the neck anchors. It's essential for structural support and movement. We look for the most prominent, often palpable, bony knot at the back of the head. The external occipital protuberance, or the inion.
The inion.
Running laterally from the inion are the curved neutral lines, superior and inferior.
Those lines sound purely structural, but they are absolutely essential for muscle mechanics.
They are the sites for the attachment of the heavy machinery of the neck and back, particularly major extensors and rotators. For example, the trapezius and sternocleidomastoid muscles attach here. The constant tension and mechanical force exerted by these muscles throughout a lifetime influence the overall morphology of the occipital bone.
So they get bigger with more muscle mass.
Exactly. In individuals, particularly males with greater muscle mass, these processes, the inion and the neutral lines, are often far more pronounced, a key indicator used in sex estimation.
And circling back to the sutures, the lambdoid suture in this posterior view often shows a unique variation, doesn't it?
It does. The source material highlights that sutural bones, or Wormian bones, are quite common along the margin of the lambdoid suture, especially in the vicinity of the lambda.
Wormian bones.
These are small, irregular, isolated bones that form entirely within the suture lines due to accessory centers of ossification. While usually an incidental finding, their presence in high numbers can sometimes be associated with underlying developmental syndromes or genetic disorders, but for most people, they are simply an architectural variation.
The outside of the skull is truly a roadmap of muscle attachment, major joints, and critical weak points protecting vital arteries. Now let's flip the skull over and look at the dramatic interior architecture where the brain itself is cradled.
The inner landscape.
When we look at the interior surface of the cranial base, we see three distinct descending steps or depressions designed to cradle the brain, creating three major zones: the cranial fossae anterior, middle, and posterior.
Think of it as a terraced landscape carved to fit the specific shape of the brain lobes. The anterior cranial fossa is the highest, shallowest, and smallest of these terraces. It is designed to accommodate the frontal lobes of the cerebrum.
What are the specific borders that create the floor of this zone?
Its floor is formed by three key bones: the frontal bone, which creates the roof of the orbits anteriorly, the ethmoid bone centrally, and the lesser wings of the sphenoid bone, forming the sharp posterior boundary.
And central to this fossa, right in the midline, is an incredibly thin, almost fragile sheet of bone belonging to the ethmoid, the cribriform plate.
This plate is perhaps the most important component in terms of sensory interface. It's thin, perforated like a sieve, and its function is singularly focused. It allows the delicate olfactory nerve filaments,
Cranial nerves.
cranial nervi, responsible for smell, to pass directly from the superior part of the nasal cavity up through the perforations to synapse with the olfactory bulb, which rests on top of the plate.
So this is the main gateway for our sense of smell to reach the brain. But this delicate structure sits right in the path of potential impact. What are the clinical vulnerabilities?
The vulnerabilities are immense. Fractures involving the ethmoid and the cribriform plate are major life-threatening concerns. Right in the midline, anteriorly, there is a small depression called the foramen cecum. This typically transmits a small vein draining the nasal mucosa into the superior sagittal sinus.
Okay.
If the bone around the cribriform plate or the foramen cecum fractures, a common occurrence in high-impact facial or frontal trauma, it can breach the dura mater.
And that breach leads directly to CSF leakage.
Exactly. You get leakage of cerebrospinal fluid into the nasal cavity, a condition known as CSF rhinorrhea. This is dangerous not just because of the fluid loss, but because that fracture essentially creates an open, uncontrolled pathway for pathogens.
Because the nasal cavity isn't sterile.
It's highly non-sterile, and any connection allows bacteria to travel directly into the meninges, leading to a high risk of bacterial meningitis or a brain abscess.
That structural fragility dramatically raises the stakes for head trauma. What anchors and stabilizes the brain membranes in this area?
That role belongs to the vertical midline projection of the ethmoid bone, the crista galli.
Which means coxcomb.
It does. This strong vertical crest acts as the anterior attachment point for the falx cerebri, the large fold of dura mater that separates the two cerebral hemispheres. Additionally, the small anterior and posterior ethmoidal nerves and vessels must pass through tiny canals near the lateral edges of the cribriform plate, right where the ethmoid meets the orbital plate of the frontal bone, underscoring the incredibly compact design.
All right, moving back and dramatically downward, we encounter the middle cranial fossa. If the anterior fossa was shallow, this one is sprawling, often described as butterfly-like, broader and deeper, and it holds the temporal lobes.
This is truly the skull's administrative hub. It is formed primarily by the body and greater wings of the sphenoid bone and the hard, wedge-shaped petrous parts of the temporal bone. It is an extremely complex intersection of major arteries and nearly every cranial nerve destined for the eyes, face, and jaw.
At its geometric center is the sphenoid bone's crown jewel, the sella turcica.
The sella turcica, meaning Turkish saddle, is a central saddle-shaped depression. Its deepest part is the hypophyseal fossa, which is the perfectly tailored protective cradle for the vital pituitary gland, the hypophysis. This entire structure is buttressed and defined by the sharp anterior and posterior bony projections known as the clinoid processes.
What makes this area a complex hub, as you called it? Beyond the pituitary, what major infrastructure is running through here?
It's the meeting point of the arterial supply and the venous drainage. The internal carotid artery, after traveling up through the carotid canal, runs right into the cavernous sinus within the middle cranial fossa.
And it's not alone in there.
Not at all. The artery is literally surrounded by several crucial cranial nerves. We're talking 3, 4, V1, V2, and 6.
So an issue like an aneurysm in the internal carotid artery in this location would immediately affect nerves controlling eye movement and facial sensation. That makes the pituitary region highly vascularized and vulnerable to surrounding pathologies.
Precisely. The proximity is a massive clinical vulnerability. Now, we must navigate the foramina highway in this fossa because this is where all the sensory and motor information for the face leaves the safety of the brain case.
Let's organize this by function, focusing on the 5 main holes surrounding the sella turcica, starting with the one that sends nerves to the eyes.
That is the superior orbital fissure. It's a large, irregular gap located between the greater and lesser wings of the sphenoid bone. This single fissure is the main traffic controller for eye function. It transmits the nerves that control eye movement, the oculomotor, trochlear 4, and abducens nerves.
3 nerves just for eye movement.
And it also transmits the ophthalmic division of the trigeminal nerve, V1, which provides sensation to the forehead and the orbit itself.
So 4 cranial nerves funnel through one fissure to manage vision and sensation in that area, and the other divisions of the massive trigeminal nerve, V.
They get their own dedicated tunnels. Just posterior and slightly inferior to the superior orbital fissure, you find the perfectly circular foramen rotundum. This transmits the maxillary division of the trigeminal nerve, V2, destined for the midface and upper jaw.
V2, okay.
Moving slightly posterolateral, the tunnel gets bigger and oval-shaped, the foramen oval. This transmits the mandibular division of the trigeminal nerve, V3, destined for the lower jaw and the muscles of mastication.
This incredible clustering V1, V2, and V3 passing through 3 distinct holes just inches apart really illustrates the compact efficiency of the cranial base design.
And we can't forget the vascular supply to the cranial lining. We discussed the risk associated with the middle meningeal artery near the pterion. It gains entry to the cranium right here via the foramen spinosum.
The foramen spinosum, transmitting the middle meningeal artery, is situated posterolateral to the foramen oval, a very small hole for such a critical vessel.
It is. Finally, we encounter the oddly positioned foramen lesserum, located medially to the petrous apex. This hole is interesting because, in life, its floor is largely blocked by fibrocartilage. It doesn't allow any major nerves to pass directly through its base.
So it's not really a foramen, a hole, in the traditional sense?
Not at its base, no. Instead, the internal carotid artery, along with its associated sympathetic nerve plexus, passes superior to this structure as it enters the middle cranial fossa.
The foramen lacerum is therefore more of a landmark than a direct passageway in its lower section. That's a lot of crucial infrastructure packed into a very small central area, underscoring why the middle fossa is the functional switchboard for the entire face and head.
Absolutely.
Now we move to the final, deepest, and largest chamber, the posterior cranial fossa. This is the structure that links the brain to the spinal column and houses the control centers for coordination and basic life functions.
This deep chamber is formed predominantly by the massive occipital bone, anchored anteriorly by the petrous parts of the temporal bone and parts of the sphenoid. It houses the brainstem, the pons, and medulla oblongata, as well as the entire cerebellum, the primary coordination and balance center.
The single most prominent feature, the structure that makes the connection possible, is the massive central opening.
That is the foramen magnum Latin for the great hole in the occipital bone. This opening is the vital connection point between the brain and the body. It transmits the lower portion of the brainstem, the medulla oblongata, as it transitions seamlessly into the spinal cord.
And more than just the spinal cord goes through, right?
Yes. It also allows the passage of the protective meningeal layers and, crucially, the paired vertebral arteries, which travel up the neck to supply the posterior circulation of the brain.
The foramen magnum is essentially the main nerve trunk and arterial input. Right near it, we find another major complex opening, the jugular foramen.
The jugular foramen is a marvel of anatomical efficiency and complexity. It's located between the temporal and occipital bones, and it's typically large and irregularly shaped. The source material notes that it is usually divided into 3 distinct parts by dural folds, separating the different structures that exit here.
What are the vital contents that pass through this large, complex opening?
This is the primary venous exit ramp for the entire brain. It transmits the internal jugular vein, which drains most of the blood from the skull. Critically, it also transmits three vital lower cranial nerves:
Which ones?
the glossopharyngeal, the vagus X, and the accessory nerves. These nerves are essential for vital functions like swallowing, voice production, and controlling the muscles that move the head and shoulders, like the sternocleidomastoid and trapezius.
So we have the primary input, the foramen magnum, and the primary venous output, the jugular foramen, right next to each other, maintaining the flow of information and blood supply.
And separating the middle and posterior fossa is that incredibly hard, dense, structural wedge of bone known as the petrous part of the temporal bone. This is the vault that protects our primary sensory apparatus,
The inner ear.
the inner ear and balance mechanisms. On the posterior face of this petrous ridge, we find the entrance, the internal acoustic meatus.
That's the dedicated gateway for two key cranial nerves.
Exactly. The internal acoustic meatus transmits the facial nerve, which controls all the muscles of facial expression, and the vestibulocochlear nerve, 8, which is solely responsible for carrying information regarding hearing and balance. The petrous bone is arguably the densest bone in the entire skull, specifically because it must protect these highly delicate sensory organs and their associated nerves from external trauma.
The interior of the skull is a logical, three-tiered, highly organized system of valleys, ridges, and complex nerve-specific passageways. That detailed perspective now enables us to look at the same structure from the bottom up, the view that provides leverage for the neck and attachment points for the face.
The chassis, as you called it.
Looking at the inferior surface, the base of the skull from below can be overwhelming. It's an intricate landscape of sharp processes, anchoring points, and the external openings of the foramina we just discussed internally. If the interior base is the cradle, the exterior base is the chassis.
This is the absolutely critical interface where the skull meets the spine, where all the powerful neck muscles attach, and where the mouth and pharynx structures are supported.
Starting at the very front, we find the roof of the mouth, the hard palate.
The hard palate is a robust, bony partition that separates the nasal cavity above from the oral cavity below. It's formed by the meeting of two bone pairs. Anteriorly, it's the large palatine processes of the maxillae, and posteriorly, the smaller horizontal plates of the palatine bones.
And they meet at sutures, just like the top of the skull.
Yes, these plates meet at the crucial median palatine suture and the transverse palatine suture. And even this bony palate has its own critical infrastructure running through it.
I was going to ask.
The greater palatine foramen is a major opening located near the posterior edge of the alveolar arch. This hole transmits the greater palatine nerve and vessels, providing essential sensation and blood supply to the hard palate. Without it, the roof of your mouth would have no feeling.
Moving back from the hard palate, the sphenoid bone projects downward dramatically.
Those are the crucial paired pterygoid processes of the sphenoid bone. These structures project inferiorly from the junction of the middle and posterior fossa and are strong, dedicated attachment points for the pterygoid muscles. These are some of the most powerful muscles of mastication, essential for lateral or side-to-side jaw movements.
And immediately behind the hard palate, the nasal cavity opens up into the nasopharynx.
Those are the choanae, or posterior nasal apertures. Their structure is defined by sharp bony borders. They are bordered medially by the vomer, below by the palatine bone, and laterally by those prominent pteryoid processes. These are the precise exit points for air traveling from the nasal cavity into the throat.
And as we move further laterally in the base, we revisit the area where the single movable joint, the TMJ, operates.
From this inferior perspective, the strong sweep of the zygomatic arch leads us directly to the articulation point, the mandibular fossa of the temporal bone. This concave socket is where the condylar process of the mandible hinges. Understanding the exact geometry here, how deep the fossa is, how far the articular tubercle projects, is crucial for understanding the mechanics and common pathologies of the temporomandibular joint.
Shifting to the posterior subdivision of the inferior surface, we are back around the foramen magnum, the junction where the skull meets the vertebral column.
The key structures here are the paired, smooth, kidney-shaped occipital condyles, located laterally to the foramen magnum. These are the articulating surfaces. They sit directly upon the superior facets of the first cervical vertebra, the atlas.
The atlas C1.
This crucial articulation, the alento-occipital joint, is fundamentally responsible for allowing us to perform the essential yes-nodding motion of the head.
Now we have those two unmistakable bony projections on the side of the head, both belonging to the temporal bone. The sharp, delicate one, and the larger, muscular anchor.
Let's start with a thin, needle-like styloid process. This structure projects sharply anteriorly inferiorly and acts as a delicate, though vital, attachment site for several muscles and ligaments, including those of the pharynx and the tongue. It helps anchor the hyoid bone superiorly.
Contrast that with its robust neighbor.
The larger cone-shaped and far more robust mastoid process projects just posterior to the external ear canal. This structure serves as the primary attachment site for powerful neck muscles, most notably the sternocleidomastoid. Its size and robustivity, as we noted before, is a hallmark of sexual dimorphism, becoming far more pronounced and pneumatized, so filled with air cells in males after puberty.
Since we are viewing from the bottom, this is our chance to synthesize the vital passageways that enter and exit the cranium from the outside.
This external view puts their relationship in perspective. We can clearly see the large entrance to the carotid canal, which is positioned just anterior to the jugular foramen. This marks the entry point for the internal carotid artery, the brain's main anterior blood supply, as it begins its complex S-shaped course through the pectus bone to reach the middle cranial fossa.
And what about the enormous exit point for the brain's venous drainage?
That is externally visible as the large jugular fossa, which forms the posterior lower boundary of the jugular foramen we discussed earlier. This is the start of the internal jugular vein, where all that venous blood begins its journey back to the heart. We also find the specialized small tunnel for the tongue nerve, the hypoglossal canal.
Where is that located relative to the articulation point?
It's located superiorly and anteriorly to the occipital condyle. This canal transmits the hypoglossal nerve, cranial nerve 12, which is solely responsible for controlling all the intrinsic and most of the extrinsic muscles of the tongue.
That detail is staggering. Every millimeter of the base is structurally accounted for, supporting the brain, receiving sensory input, and anchoring massive movement.
And we must also give credit to the tympanic plate of the temporal bone. This bony plate is crucial because it supports the floor and anterior wall of the external acoustic meatus, the entry to the ear canal. Critically, it provides a vital physical separation.
A separation from what?
Anteriorly, it separates the external acoustic meatus from the large nearby parotid gland. This separation minimizes the risk of infection spreading directly from the gland to the delicate structures of the middle cranial fossa and the internal ear.
That concludes our tour of the complex geometry of the adult skull. But we need to remember that the skull is far from a fixed object. It's a dynamic, transformative structure that records the history of our lives. Let's move into part 5. The dynamic skull, how it's born, how it grows, and what happens when that growth goes wrong.
The story of the skull.
The neonatal skull is structurally and proportionally unlike the adult version. The most striking difference is the sheer size disproportion. The newborn calvaria, the dome housing the brain, is dramatically larger relative to the small, underdeveloped facial skeleton and mandible.
This disproportion is necessary because the skull's primary function in infancy is to accommodate the explosive rate of brain growth, which is fastest in the first year of life. When you look at the face, the maxillary and frontal sinuses are virtually undeveloped, the maxilla and mandible are small, and crucially, the major muscle anchors like the mastoid process are not yet prominent.
They haven't been used yet.
They only develop as the neck muscles begin to be used extensively.
And the bones of the calvaria aren't fused yet. Instead of hard, interlocking sutures, you have the famous soft spots.
Those are the fontanelles, or little fountains. These are wide areas of dense, fibrous connective tissue separating the cranial bones in the newborn. They are brilliant evolutionary design features serving two vital interconnected purposes.
Okay, what are they?
First, they allow the bones to overlap slightly during the passage through the birth canal, a process called molding, which reduces the effective skull diameter. Second, and perhaps more importantly post-birth, they allow for the extremely rapid, massive expansion of the underlying brain.
How many fontanelles are there, and which ones should we, the listeners, be most aware of?
There are 6 major fontanelles. Clinically, the most important is the diamond-shaped anterior fontanelle. This is located at the meeting point of the future sagittal and coronal sutures, the future bregma. This is the largest, and it's vital because its open status is used by pediatricians to clinically monitor brain growth, hydration status, and most importantly, intracranial pressure.
And its closure is a key benchmark of development.
Yes, it is the last to close, typically fusing late, somewhere between 18 months and 3 years of age. Contrast that with the small, triangular posterior fontanelle at the future lambda, which closes rapidly, usually within the first few months of life. The remaining four are the smaller paired sphenoidal and mastoid fontanelles, which generally close within the first year.
So brain growth is explosive early on. How long does this rapid phase last, and how does the bone remodel itself from those thin neonatal plates to the thick adult sandwich structure?
Skull growth continues rapidly until around the 7th year of life, which is when the brain achieves near adult size. After that, growth slows dramatically. The process involves continuous bone accretion, or adding new bone, at the edges of the sutures, and resorption, removing bone on the inner surface, increasing the overall size of the head.
So it's growing on the outside and getting carved out on the inside.
In a sense, yes. And crucially, as the skull expands, the diply layer begins to form and thicken, gradually changing the bone from a thin plate into the compact, cancellous compact adult structure.
Is that thickening uniform?
No, it proceeds unevenly. This uneven thickening is why specific parts of the adult skull, like the temporal fossa near the perineum, remain areas of relative thinness even decades later. Furthermore, the facial skeleton and mandible follow a different, slower growth trajectory than the calvaria, achieving most of their adult size later in childhood and adolescence, which dramatically changes the overall skull proportions.
This delicate and highly choreographed process of bone growth relies entirely on the sutures remaining open until the correct time. What happens when this clock fails? We enter the pathology known as craniosynostosis.
Craniosynostosis is the premature fusion or closure of one or more cranial sutures. The fundamental mechanical consequence is that since the bone cannot expand perpendicular to the fused suture line, the restriction immediately inhibits brain growth in that direction. The skull then attempts to compensate by growing aggressively parallel to the fused suture, resulting in often severe skull deformation.
The source material indicates the causes are complex and heterogeneous, ranging from genetic factors to mechanical forces acting on the skull in utero. But the results are predictable based on which seam closes first.
That's right. The most common type, affecting about half of all cases, is the premature fusion of the sagittal suture, which runs along the top midline. This results in a condition called scaphocephaly.
Scaphocephaly gives a very distinct, elongated head shape.
Yes, the term literally means boat-shaped head. Because expansion is blocked laterally, or side to side, the skull is forced to grow anteriorly and posteriorly, resulting in a long, narrow, wedge-shaped skull with a high forehead.
What are the other major types?
The second most common type involves the coronal suture, running from ear to ear. If this fuses prematurely, the result is either brachycephaly if bilateral fusion occurs, or plagiocephaly if only one side fuses.
If the coronal suture fuses bilaterally, on both sides, how does the skull compensate?
If the side-to-side growth is blocked, the skull becomes short and broad, so brachycephaly and growth must occur vertically. Unilateral fusion, plagiocephaly, is more severe in its asymmetry, leading to a skewed, flattened deformation on the affected side and compensatory bulging on the opposite side.
The consequences of this restricted growth must extend far beyond cosmetic concerns.
Absolutely. The clinical implications are serious. The restricted volume prevents normal brain expansion, leading directly to raised intracranial pressure and potentially hydrocephalus or excessive fluid in the brain. Furthermore, if the orbital openings or the cranial-based geometry are affected, it can cause visual impairment or even nerve compression.
So surgery is often required.
Because of the risk to brain development, early surgical intervention, ideally before the age of 3, is often required to release the fused sutures and allow the brain to expand normally.
This all highlights that the skull is a system of synchronized growth, not just one unit. We must also touch on the different growth timeline for the face.
That's crucial context. The maxilla and the upper nasal skeleton achieve most of their growth relatively early, typically by age 7 to 10. However, structures like the orbital rim, the nasal septum, and the overall upper nasal skeleton continue to grow subtly into the second decade of life.
And that's tied to puberty.
This delayed growth is partly influenced by secondary sexual characteristics and hormonal changes during puberty. Understanding these staggered growth spurts is vital for fields like orthodontics and maxillofacial surgery, ensuring treatments are timed to coincide with natural developmental periods.
It's incredible that a seemingly fixed structure like bone can be so dynamic and consequential over a lifetime. Let's now transition to how this final, adult, highly detailed structure is used to identify individuals, which is the intersection of anatomy and law.
The forensic side.
In forensic anthropology, the skull is one of the most reliable pieces of evidence, but its reliability as an age indicator decreases dramatically after early adulthood.
The foundational reason is that age estimation relies on predictable, highly regulated developmental processes that happen early in life. For juvenile and subadult skeletons, dentition, the development, eruption, and maturation of teeth, is by far the most accurate method we have.
The timing of tooth development is a biological clock that rarely deviates.
It's remarkably reliable. We know the standard chronological framework. The eruption of primary, or baby teeth, occurs between 6 months and 3 years. The eruption of permanent teeth starts around age 6, with the full set, including the crucial third molar or wisdom tooth, typically erupting between ages 18 and 21. Dentition provides a highly reliable chronological framework right up into the 3rd decade of life.
Once that reliable clock runs out, forensic experts often turn to the anatomical joints we discussed earlier, the cranial sutures. How reliable is suture closure in older adults compared to teeth in adolescents?
It is far, far less reliable, but it provides a general trend. We noted that the spheno-occipital synchondrosis closing between 13 and 18 years is a gold standard for adolescents. For adults, the trend is that fusion occurs internally on the endocranial surface before it is visible externally on the ectocranial surface.
What are the typical adult closure times?
The fusion of specific sutures, particularly the sagittal and coronal, generally begins in the late 20s and is often completed by the 4th decade of life. However, this is where the caution comes in.
Underscore the critical insight about the variability of suture closure.
Our sources emphasize that suture closure is highly variable, often incomplete even in very old age, and differs significantly between individuals and across different populations based on factors we don't fully understand. Therefore, it is not a reliable clock for exact adult age estimation.
It's a suggestion, not a fact.
It can only be used to provide a very general age range: young adult, middle adult, old adult, and should never be used as a standalone forensic marker when assessing adult age. The evidence from dental development is far more predictable.
Beyond age, the skull is exceptionally informative about sex, particularly after puberty. The skull is highly sexually dimorphic, meaning that hormones cause specific traits to reliably differ between males and females. The source suggests that when the whole skeleton is available, the accuracy of sex estimation based on skull traits is extremely high.
Around 90 to 95%, yes. The differences fundamentally reflect the influence of testosterone and mechanical stress, leading to greater overall robusticity in males. Males generally have larger, heavier skulls, and their muscle attachment areas are far more pronounced to support greater neck and jaw muscle mass.
Let's detail those specific morphological traits that forensic anthropologists examine.
We look for rougher, more pronounced muscle anchoring sites. For example, males have a larger, more robust mastoid process, that anchor behind the ear, and a more prominent external occipital protuberance, the inion, at the back of the skull.
What about the face?
In the face, male supraorbital margins, the brow ridges, tend to be thicker and blunter, and the zygomatic arch is often more heavy and flared. Finally, the male chin is typically squarer and more everted.
And the female skull presents the inverse traits.
Correct. The female skull is typically smaller, lighter, and smoother. Muscle attachment areas are less robust. Females generally have sharper, thinner orbital margins and a chin that is usually more pointed or rounded. The entire contour is often smoother due to less bone deposition influenced by muscle pull.
Finally, we address ancestry estimation. This is a complex topic, but the anatomical basis is clear. It relies on population-level variations in facial morphology.
It relies on observing variations in morphological traits, such as the shape of the dental arch parabolic versus U-shaped, the projection of the midface relative to the brow ridge, and the specific shape and inclination of the nasal aperture, the piriform aperture.
Is this as reliable as sex estimation?
No. The source material is very careful to note that while these traits show general population-level trends, they are subject to wide variation due to centuries of population mixing and genetic complexity. Therefore, ancestry estimation is considered significantly less reliable than sex estimation. It is an approximation tool used to narrow down a pool of possible identities, rather than a definitive identifier.
And the ultimate goal of applying all this anatomical knowledge is identification. When standard identifiers fail DNA, fingerprints, dental records, the skull is used for forensic facial reconstruction.
This is where the structural detail we have spent this time diving into becomes paramount. Forensic facial approximation uses the bone structure to generate a likeness. The core principle involves applying standard measurements of soft tissue thickness over specific bony landmarks.
They're essentially translating a 3D bone map into a 3D surface map.
Exactly. Standardized thickness data, derived from statistical averages for specific populations and sexes, are applied to landmarks like the zygomatic arch, the external acoustic meatus, and the orbital margins. This generates a likeness that reflects the underlying bone geometry. The crucial takeaway is that the reconstruction's primary goal is not perfect identification, but rather to elicit recognition and leads from the public. It relies entirely on the predictable relationship between the rigid structure of the 28 bones and the surface features that define our human identity.
We have completed an exhaustive deep dive, covering the intricate architecture of the human skull, from its cellular development to its application in forensics. To quickly summarize our three major takeaways.
First, remember the fundamental structural trade-off recorded in the skull's dual developmental origin. The complex, cartilage-derived cranial base, so endochondral, designed for intricate joints and slow growth, versus the simpler, membrane-derived vault, intramembranous, designed for rapid expansion and shock absorption.
Second, recall the incredible interconnected highway system of the cranial fossa, the three descending terraces, which serve as the central nervous system switchboard. Every major function, from smell through the cribriform plate to venous drainage exiting the jugular foramen, is funneled through specialized tunnels.
And third, appreciate the dynamism of this structure. The dramatic changes it undergoes from infancy, with the 6 wide fontanelles accommodating rapid brain growth, through the critical closure of the spheno-occipital synchondrosis in adolescence, which permanently marks the end of key structural growth.
We have spent this time appreciating how the shape, robusticity, and specialized holes of the skull tell a complete story of protection, development, and personal identity. What's profoundly fascinating here is that the entire history of human evolution, the expansion of the brain, the transition to bipedalism, the retraction of the face, is recorded and archived in the orientation and size of structures like the external occipital protuberance, the neutral lines, and the shape of the orbital sockets. This structure doesn't just protect life, it archives human lineage and mechanical history.
So here is a challenge for you, the learner. Next time you hear a reference to a skull fracture or head injury, don't just think bone break. Consider the precise geometry. Which fossa was affected? Which suture line was strained? And most critically, which major artery or nerve like the middle meningeal artery running deep to the thin pterygium or the internal carotid passing adjacent to the sella turcica might have been compromised by that specific piece of geometric damage? Understanding the skull's intricate architecture is the first step to understanding the fragility and resilience of life itself.